thank you for your attention. My task this afternoon was to give an update on long-acting interferons, which is a very current topic these days. And the general remarks I'm going to make today are outlined here. I will talk about some general comments about interferons, their use in ETPV and myelofibrosis. Because there's so much attention directed towards the molecular response, we'll talk about that and then make some concluding remarks and take-home points. So general remarks about interferons are that they were discovered about 50 years ago by Dr. Lindenmann from Switzerland. They are proteins, specifically cytokines, and there are three types of interferons, types 1, 2, and 3. The type 1 is an alpha interferon that we're mostly concerned with as clinicians. Type 2 are the gamma interferons, which are involved in cellular immunity and tuberculosis, and the type 3 are similar to the type 1s, and they're not particularly relevant to us in clinical hematology. Dr. Lindenmann unfortunately died in January of 2015. And in the obituary by Gina, who writes a lot about medicine for the New York Times, she pointed out that although he discovered interferon, he didn't really keep up with the times, and he tried to clone interferon by mouse breeding. And it was his student, Charles Weissman, who was interested in molecular biology, and when he went to his laboratory on his own in about a month or two, cloned interferon in Zurich, Switzerland, and that was a bit of disappointment to Dr. Lindenmann at the time. In the obituary, she mentions many of the uses of interferon, but doesn't talk about their use in the myeloproliferative diseases, which sort of disappointed me. So what is a cytokine, for those of you who are not familiar with that or need just a little bit of refreshing? They are related to signaling molecules. They're major regulators of the immune system. They are therefore released by cells involved in immunity, and have their effect is rather localized because their function is either paracrine or autocrine. And as you probably all know and are aware, they augment proliferation, differentiation, effective functions, and survival of leukocytes. So they're very important from the standpoint of cellular function. Some activities of the interferons that are of interest to hematologists and oncologists are reviewed here. They induce expression of pro-apoptotic genes causing cell death. They inhibit angiogenesis and alter the microenvironment. And I think that's very important, as you'll see in a slide that has a very clinical relevance in treatment of polycythemia vera. They enhance the immune response, as we just mentioned. They suppress proliferation of hematopoietic progenitor cells. They promote cycling of dormant malignant hematopoietic stem cells, as recently shown by Dr. Mullally in Boston and recently by Joe Percal in humans, and their affect megakaryopoiesis. But what is it about the interferons that are specifically interesting to us who are concerned with the MPNs? And that is shown in this slide, that they specifically affect the action of PDGF by activating G0 cells for G1 transport and S-phase entry. They inhibit erythroprogenitors in vitro. They're anti-angiogenic, very, very important because of the vascular aspects of the myeloproliferative neoplasms. They directly repress megakaryocytopoiesis by inhibiting thrombopoiesis. They're involved, as you already heard, several speakers talked about their importance of JAK-STAT signaling in the MPN, and interferons are involved with that. They specifically affect PV stem cells, as I just mentioned, as shown by Mullally and Percal. So there are three general types of pegylated interferons. First of all, there's the Peg intron that's made by Merck. That's alpha-2b. That is a pegylation involving a urethane bond, which is relatively unstable. And it is more likely this molecule is more likely to hydrolyze, and therefore the action of a PEG intron requires an injection usually twice a week, although it's customarily only given once a week. PEG interferon alpha 2A, a roferon manufactured by Roche, has a much more stable amide bond, and has therefore a more prolonged concentration, and has been the standard interferon drug that most of us use in this country and abroad. And for those of you concerned about whether or not Roche is going to discontinue Pegasus for MPNs, they're not, although their market for hepatitis is certainly diminished in the United States. And Merck has discontinued most of their experimental trials in the MPNs, including, unfortunately, that at Cornell. Incidentally, there's no randomized control studies in hepatitis C, notwithstanding all the work in interferons in that disease. And there's no randomized trials except for CML with respect to the pegylated interferons, which was conducted some years ago by Merck. And at that time, it was of interest that the standard PEG interferon 2B compared to the standard regular interferon or intron showed that intron had less side effects than did the pegylated form, and that was probably due to differences in dosing. So the safety profiles are similar. The side effects are very similar as well, and I think are related to intervals between dose and patients, and rather than any quantitative difference between any of them. The most important and interesting drug is Rho-Peg interferon, as shown in the third paragraph down. This is a monopegylated alpha 2B. It's linked via a proline. It is being developed by AOP Orphan and Pharmacentia in Europe, in which there have been significant drug trials, as we'll talk about. And hopefully this will be introduced in the United States in the next year or two. So this is the Rho-Peg interferon that is being manufactured by AOP and Pharmacentia. It is unique because there's only a single isoform of interferon in comparison to the 8 to 12 isoforms in the other types of interferon, and presumably that may be related to decreased toxicity. That remains to be seen. It is long-acting, and it can be given because of the proline PEG. It can be given every 2 weeks or every 4 weeks, and the long elimination therefore decreases the necessity for administering it as frequently as the previous products that we had available to us clinically. So the question is, are there qualitative differences among the interferons? The evidence, I believe, is quantitative, but there is certainly no qualitative difference. We agree that they have similar toxicity profiles, and as I just mentioned, the differences are probably the result of the doses used, the individual variation and characteristics of the disease in the patients, and the heterogeneous methods of response evaluation. However, it would appear that quality of life might be better with the pegylated forms, and I think most people would agree with that because of the sustained level of interferon that is in the body and in the bloodstream because of the pegylated aspects of the chemical combination. So what is the clinical use in an ET, in polycythemia vera and myelofibrosis? What's the update? Let's take a look at that. In the past 25 years since interferon was first used in Europe by Heinz Gislinger and others, there have been about 25 or so studies. As you can see, that in comparison to drug trials in breast cancer, these are really minimalists maybe 500 patients altogether. The responses ranged from 70 to 100%, but very effective in ET, as you can see, either CR or PR. Discontinuation rate is rather low, 20%, with a range of 0 to 55. And of course, there's no pterogenicity or leukemogenicity associated with the interferon. And often the high doses used initially leads to toxicity and early discontinuation. And so it's about 25 years ago that we introduced interferon in PV, and pretty much the same thing has been shown in this disease. Now interferon has been reported in about 400 to 500 patients. What's important is the reduction in phlebotomy rate is very, very significant to note that interferon will not lower the hematocrit. You must phlebotomize the patient, but it will sustain the hematocrit in the therapeutic range once the hematocrit is lowered via phlebotomy. There's rapid reduction in platelet count and white count. There's relief of pruritus, very, very effective for this symptom. Reduction in splenomegaly, as you'll see, and discontinue rate is variable depending upon dose, enthusiasm of the clinician, and the complaints of the patient. What is very important in PV is the progression-free survival from thrombohemorrhagic events. And we heard in the discussion of splanchnic vein thrombosis, the issues of flow and vascular effects. And I believe the same thing is probably true in those thrombotic events that occur in polycythemia vera. But what is unique about interferon is that virtually all patients treated with this disease properly do not suffer from significant thrombosis. And when we submitted this paper for publication, the editor wrote back a query really questioning these findings. They've since been confirmed by all users of interferon, including Collagen and Hasselbach and Heinz-Gisling, et cetera. So there's something very unique about interferon and its relationship to antiplatelet effect, vascular effect, leukocyte effect, et cetera. So not only is interferon effective in treating the vascular events, but it's significant in treating splenomegaly and the fibrosis that occurs in PV and primary myelofibrosis. And more often, we have better effects in PV than in primary myelofibrosis. And Dr. Ritchie, my colleague and dear friend on the dais with me, have treated a number of these patients. This is a patient with significant splenomegaly with reduction in spleen size over the course of 2 years on low-dose interferon therapy. The residual splenomegaly was then treated with the addition of ruxolitinib very effectively, and the spleen became no longer palpable. We believe in frequently monitoring our patients with primary myelofibrosis and PV with bone marrow biopsies. We try to do that annually or biannually at the most. And this is a patient with minimal leukoerythroblastotic changes in the peripheral blood, significant fibrosis, and you can see the distorted megakaryocytes. This is the picture of the fibrosis as demonstrated by reticulin stain, and as you heard in an earlier presentation, this would be grade 2. This is the patient 3 years later with normal architecture and a grade 1 reticulin fibrotic score. On the higher magnification, you can still appreciate the abnormality of the megakaryocytes, but it takes a real degree of sophistication and frequent review of your pathologic specimens, hopefully with a appropriate hematopathologist to really appreciate these fine abnormalities. So what about the molecular changes? We first reported with Nick Cross from the UK that interferon did not significantly reduce the JAK allele burden. Subsequently, Jean-Jacques Collagen in 2008, and then Serge and Quintus Cardama and his colleagues in 2009 from the MD Anderson reported significant JAK2 allele burden changes in the percentage of patients, 24% and 14% of patients respectively. And then Heinz-Gisling, using the proline interferon, likewise reported an undetectable JAK2 allele burden in a significant number of their patients. On the other hand, we at Cornell did not find a clinical response correlated with molecular remission. And this, we'll explain that in just a minute, but this is Dr. Gislinger's findings. As you can see with row PEG, it takes at least 2 to 3 years to get a significant lowering of the JAK2 allele burden. So when we went back and looked at the findings of Collagen and Quintus Kodama and Serge, you'll note there significant change in JAK2 allele burden in columns 2 and 3, from 69 to 12%, and from 42 to and 45 to 5%, compared to our regular interferon and PEG interferon not showing any significant change. The median doses used by Collagen and Quintus Kodama were higher than those we used, and also you'll note that their toxicity, time to toxicity, was higher compared to ours. So that therefore, it probably reflects, this difference probably reflects duration of treatment and the doses that were used in the individual setting. So when we talk about that, we must always remember the limitations of all of interferon therapy. The toxicity is basically the same, but it probably is decreased with the PEGs because of the long-acting levels in the blood, but the doses are really pretty much similar. I would like to make an emphatic point about the neurological problems that sometimes we see in patients who have received interferon for 5 or 10 years. They really are basically peripheral neuritis, most often involving the feet, and then we have to lower the dose or discontinue it for a period of time. Dr. Hasselbach does not consider depression a contraindication to interferon therapy, and points out that many of the patients in Denmark and Scandinavia have the depression relieved by interferon treatment and when they go into clinical remission. But we are very concerned if someone comes in with any history of any neuropsychiatric disorder. So the therapeutic conundrum, which is not answered, whether or not it's preferable to maintain complete hematologic response with the lowest interferon dose rather than aim to JAK2 negativity. So the basic question is, can we cure MPNs with pegylated interferons? Those say yes, cite the fact that additional to the clonality changes seen with JAK2 levels down to normal or approaching normal, that there's reversal of chromosomal abnormalities, restoration of polyclonal hematopoiesis, normalization of PVR1 expression, which is a transcription factor, and suppression of endogenous erythroid colony growth. The no's say, well, you've heard about this earlier today in excellent presentations, that TET2 mutations may persist besides, despite eradication of JAK2, and as you heard earlier, TET2 may precede JAK2 and PV. In patients with complete molecular response, JAK2 cells in some EPO-dependent colonies remain. Patients who evolve to acute leukemia lose JAK2 positivity. And in MPNs of the myelofibrotic type, the higher risk molecular abnormalities seen in poor responses to interferon, such as ASSL1, E2H2, AZH, etc., those certainly play a major role in the pathogenesis of the disease. So it would certainly seem that the no's have the vote at the present time. And most recently, we've noted that because of the way we do biopsies frequently at Cornell, that if you look at cellularity or fibrosis as shown on the left, and correlate with decrease, no change, or increase in the molecular JAK2 allele burden. And these are patients that Dr. Ritchie has worked so hard with me to develop these data, that you see that there is no correlation with cellularity compared to the decrease in JAK2 allele burden. And in some patients who have had significant decreases, there is no change or even increase in cellularity and fibrosis in these patients. And conversely, in patients who have had an increase in JAK2 allele burden, there is a decrease in cellularity and a decrease in fibrosis. So the allele burden per se may not be the only answer. But we'll keep trying, and with new drugs and combinations, more research, of course, combinations of the interferon and the JAK2 inhibitors, which we'll hear about from Dr. Ritchie, we will probably reach our goal. So these are our take-home points. There are no qualitative differences among the type 1 interferons. There's a significant biological basis for the use of the MPNs. We start with low, not high doses and increase. It affects splenomegaly and marrow fibrosis. Toxicity depends upon the dose, and especially and is usually tolerable. And it's undoubtedly less with pegylated, probably less with pegylated interferons, and there's a new interferon preparation, as I talked about. And early treatment and combinations are preferable and experimental. So if we look at the rock of the MPNs, we've had a number of new drugs, including transplantation advances. We're about 3/4 of the way there, and hopefully in the next IMEDX presentation we may be able to say we've truly cured these diseases. Thank you.